You have to excuse me if I've sometimes not pronounced the right names, huh? Okay, we can start now.
Yes, please.
Bismillah ar-Rahman ar-Rahim. I would like just to say to welcome all the speakers of this interesting webinar for tonight. We have here our talk, or the title of our webinar is today the state of the art in craniomaxillofacial traumatology. And this is a very interesting subject, and we hope that all the speakers and the panelists will share their information and experience about the craniomaxillofacial traumatology in Germany and in the Middle East. And I would like to welcome our main speaker. Our main speaker is today coming from Germany, Professor Max Peter Hyland. Professor Max is now current head of the Department of Oral and Maxillofacial Surgery at the Charité University in Berlin. And he is also elected board member of the Deutsche Gesellschaft für Mund- und Kieferchirurgie, oral and maxillofacial surgeon and head of department at the Charité University in Berlin. Charité University in Berlin is the biggest university actually in Europe, and I have a good experience in the orthopedic part, definitely, but it has a huge medical complex and is a tertiary center for referral cases. Our panelist, or the panel list, headed by Professor Ibrahim Hashish. Ibrahim is the head of department of the dental and maxillofacial surgery department at Saudi German Hospital in Jeddah. He's a PhD in oral and maxillofacial, and he was also the previous dean of the dental college at the BMC in Jeddah. We have also Dr. Ahmed Abdallah. He is an MD of oral and maxillofacial from Cairo University and work now at Saudi German Hospital in Jeddah. Our next candidate is Dr. Kamal Eid Muhammad Salim. He is master degree. He has a master degree in dental and dental medicine at the Faculty of Medicine in Alexandria University, and works now also in Saudi German Hospital at the maxillofacial department since 2018. Professor Mahsin Abdul Hassan is head and oral maxillofacial department in Saudi German Hospital in Cairo. And last is Dr. Muhammad Abu Saud. He's a surgeon and oral maxillofacial department in SGH Riyadh. So I welcome all of you, and I would like now just to start our lectures by giving the microphone to Professor Max Peter Hyland. Please, Professor Max, you can start.
Yes, please. Dr. Batagi, thank you very much for the nice introduction and the possibility to share my experience in craniomaxillofacial traumatology tonight with a huge number of participants in this webinar. I'm very impressed. I work currently in Berlin, as stated before, and I'm a visiting professor to the different branches of Saudi German Hospital since many years. And I always like to come to Saudi Arabia or Egypt and work in these very excellent hospitals. So tonight we are talking about craniomaxillofacial traumatology. I just have to come forward. In Germany, we have the reasons: interpersonal violence for trauma in the facial area. We have the road traffic accidents, not as much in the frequency and how severe the accidents are in comparison to Saudi Arabia, but it's also reason in our country for craniomaxillofacial traumas. We have leisure activities, especially by younger patients. We have the homework that is dangerous and causing some falls from height. And so when these patients are coming to the emergency room, what is important from our point of view? First of all, we have to look at the vision, at the orbital region, whether there's an increasing pressure that we have to address. Of course, we have patients with acute problems in terms of bleeding, and sometimes even the airway can be challenging. So what is urgently done by us in the ER? We can do packing if we have bleeding from the nasal area or the oral cavity. If we have a blocked airway and the intubation is not possible, we can urgently perform tracheostomies. If we have a retrobulbar hematoma, the decompression, for example, bilateral orbitotomy, can be done even in the ER. And of course, if we have some severe soft tissue injuries, we have to address this. The airway is important not only for us, but also for the patient and the anesthesiologist. So if we have huge trauma, always take care if you take it by the nasal way, not to get the wrong way, because it can be damaged and there can be a direct connection to the brain. So especially in the very complex cases, we prefer for surgery very often the submental intubation that started with an oral tube and is intraoperatively coming outside in the submental area. And with this, we have the possibility to address even the occlusion and also the nasal bones and the nasal part of the patient. So with this, we are very flexible, and at the end of the surgery, we can switch back to an oral tube. So in very severe cases, we prefer this instead of performing a tracheotomy that will last for longer time. The diagnostics of choice in this kind of patients is 3D imaging. Whether you do a CT scan or you do a cone beam scan, it doesn't matter, but we need three-dimensional information to address really the severity of the fractures. In earlier times, non-surgical treatment was the main part of treatment. And it started at First World War that we did, or the former doctors did some kind of conservative treatment like this, or like this on the ward. This is definitely over today. And the treatment of choice in most of the patients is open reduction and internal fixation, like in general trauma surgery. However, plates and screws are a little bit smaller. The primary objective for us is the occlusion of the patients. For this, we need to fix the upper and the lower jaw in the individual occlusion during our treatment, that we are really safe regarding the outcome of our patient. When to do now the intermaxillary fixation? It can be even done in the emergency room if we want to do it for a temporarily fixation of segments. We can do it intraoperatively just before the fixation. If we want to go for conservative treatment, we need a good intermaxillary fixation. And if we have a separate dental trauma, of course, we have to address this. We can use arch bars, we can use braces intraoperatively. However, if we take something with wires, we have to really take care, because usually we have a huge number of perforations of our gloves. And for this, very popular and increasing getting popular are these kinds of intermaxillary IMF-screws. However, with this, we have the risk of harming some dental roots. The more complex the fracture is, the more stable the intermaxillary fixation must be. If we have a conservative treatment for some weeks, we need a stable intermaxillary fixation. If we want to have a functional follow-up treatment, we need good anchorage. In easy cases, on the other side, the intermaxillary fixation can be removed at the end of surgery. And if the patient is as an outpatient with IMF, he always has to wear a scissor, because if in case of vomiting, he has to act very urgently. Now coming to the mandible area. In the mandible, we have to address the muscle forces. And for this, we have different types of fixation regarding the bony situation, regarding the occlusal situation, and regarding the severity and complexity of the fracture. We have some general principles in the mandible area from the load-bearing and the load-sharing type of osteosynthesis. And with this, the load-sharing are the more easier fractures. We have a good occlusion, we have a good compliance of our patients. And in these are the more frequent cases, we use mini plates with monocortical screws using an intraoral approach. Load-bearing on the other side, more complex fractures, atrophied mandibles or severe fractures, unstable occlusion, bad compliance of the patient. In these cases, we use reconstruction plates with bicortical screws, and for this, we need an extraoral approach. If we are going for the load-sharing osteosynthesis with mini plates, Jean P. was the one who described it very nicely, and it's still valid, where to put the plates in the ideal line of osteosynthesis. Just an example, a mandibular angle fracture, the tooth is also fractured and has to be removed. And this is the postoperative X-ray, and you see this line, the mini plate put on the internal oblique line, and this is as it was described by Jean P. If we have severe fractures, in this case of a BRONJ patient with necrosis of the jaw, so we have a very weak bone, and in this we need on the other side the reconstruction plate. Remember, load-bearing osteosynthesis, extraoral approach, and you can use hand-banded reconstruction plates, or you can really use patient-specific reconstruction plates. And we did it in a multi-center study, and it's working very nicely. So this can even be used in trauma patients. So with a defect or without a defect, you can use these CAD/CAM plates even in trauma cases. So I want to a little bit focus on the condylar region in this lecture, because this is maybe a little bit, there's a shift of treatment towards open reduction and fixation. So more and more we are using surgery in this kind of fractures. And for us, you should separate the region in the condylar head region, the neck, and the subcondylar region, because it differs a little bit regarding the approaches. Spiesel and Schroll were the ones who described it a little bit more detailed. And Neff is the one who described also the intracapsular fracture situation regarding type A, B, and C. The clinical features in these kind of patients are pain, limited mouth opening, deviation, malocclusion, maybe a lateral open bite, or even a bilateral open bite if we have bilateral condylar fractures. In these cases, especially, conventional X-rays are not sufficient for treatment planning. So we really need a 3D imaging, oops, the wrong way, to address the situation of the fracture, how to deal with the treatment, and what is indicated and what not. The approaches to come to this area, if we have condylar head fractures, or then we have to go by a preauricular or retroauricular approach. We would prefer the preauricular approach. In the middle, we can use the transparotideal approach, and if we're going more down, we can even come from transoral or submandibular or retromandibular. The indications for open reduction and internal fixation in the condylar regions are displacement of condyle into the midcranial fossa, foreign bodies in the joint space. If we have a complete lateral dislocation of the condyle, no other way of treatment. For example, if a patient is an epileptic patient and we can't use IMF postoperatively, the relative indications are the angulation, the dislocation of the fracture, the overlap of the fragments, the severity of the displacement, and in cases of panfacial fracture, where we need the complete intact mandible for orientation of the midfacial complex. What I like very much is the transparotideal approach for these, let's say, lower condylar neck fractures. It's a small skin incision, and we incise also the parotid capsule, and then we go bluntly through the parotid directly to the bony surface. because then we are exactly between the branches of the facial nerve. We can clearly identify the fracture line. The reduction and the control is a little bit difficult because the view is really limited. And of course, we want to avoid bleeding from the retromandibular vein, then the fixation, and then the multi-layer closure. This is the principle. See, the incision is really in between the facial branches. And this is just a case example. You see the orientation towards the earlobe, small incision, the parotid capsule. The capsule is opened, and then you go bluntly through the gland to the bony surface. You're landing directly on the fracture. Then the reposition is a little bit difficult because the view is not huge. Then you have a huge plate to come in. And then during drilling, you really don't see anything. And afterwards, you double check, you see the reduction and the fixation, and then closure in multiple layers. So I like this approach very much, and it's quick and easy, and it really gives you a good shape of the restored mandible for orientation, especially in complex cases. However, there are some colleagues that described you can do the same by endoscope assistance. I have no personal positive experience with this, so I don't do this, honestly. In cases of fracture treatment of the condylar region, early active mobilization, sometimes even physiotherapy afterwards, is indicated in this specific group of patients. What about the midface? The midface, of course, you all remember the buttresses in vertical and horizontal planes, especially the two anterior vertical buttresses have to be addressed. And again, conventional imaging is not sufficient for treatment planning of midfacial fractures, especially when they are around the orbit. Nowadays, we need CT scans and at least at a slice distance of 1 millimeter or less, because in some cases we use the imaging to get some patient-specific implants to be produced. And for this, we want to rely on the immediate first imaging to avoid further exposure of our patients. Surgical approaches in the midface have to balance a risk against the exposure. We have the risk of the scar, of ectropium, nerve injury, and bleeding. And however, approaches that can be used are the coronal approach, upper and lower eyelid approach, intraoral approaches, and sometimes we have also existing lacerations. Just an example of a simple zygoma fracture incision, I would call it a little bit like subtarsal incision. You go very directly through the orbital muscle to the bony surface. You expose the bone, you see the fracture. Then I make a step incision on the cheek, put the Strohmeyer hook inside under the bone of the zygoma. Then under manual palpation, you make the reduction, reduced fracture, mini plate in place. Then for orbital reconstruction of the orbital floor, and use these resorbable membranes. I will come to this in a minute. You can shape it a little bit individually, put it in like a blanket on the floor. And then in earlier days, I put a drain in. Nowadays, I don't put a drain in. So forget this. Just closure of the skin, quick, easy, and excellent cosmetic results. So what to use for orbital wall reconstruction? You can use some kind of resorbables. I don't like the PDS foils. They are too thick and too stiff. I prefer this Etisor patch that is originally indicated for dural repair. So it's not indicated for orbital wall officially, but it's working very excellent. And of course, if you have more extended fractures, you have to think about Titaniummeshes. You can get them pre-shaped or pre-bended, or you can get them individually for your patient. Individually, however, it needs that you send your data somewhere, you make a virtual planning and get the implant back. That takes time and is expensive. However, if you remember the geometry of the orbital cavity, it is sometimes in extended cases really needed to reconstruct the correct orbital volume. And for this, these meshes are really a great help. Especially in secondary cases, these individual implants make life of surgeons much, much more easier. If you put something in like this, intraoperative double check by imaging, especially 3D imaging using mobile devices, is of big help. They are very fast, easy, allow immediate revision, and of course, then you don't need any post-operative imaging. As you can see here, in contrast to orthopedic surgeons or surgeons, we don't have to dress this because we are at the end of the procedure and the face and the oral cavity are non-sterile anyhow. So for this, we are very practical. You can get nice imaging intraoperatively to check the position of the mesh. And with this, you're on the very safe side. Even in extended bilateral cases, you can get nice imaging intraoperatively. And even you can combine these imaging devices with navigation in very, very selected cases. For example, here you can see like a coronal approach, and in really severe displaced multiple segments, it can be a little bit difficult to get the orientation, where to put the zygoma back. And with the navigation, before mirroring the other side to the affected side, you can get an idea where your zygoma should be positioned. However, as you can see here, we did the mirroring, then in different views, and then we did our surgery, get the intraoperative imaging, and then we have a view of everything. You see there's still a difference between the virtual plan of mirroring and the achieved intraoperative result. And then you have to address this. Do you further correct it or you leave it as acceptable? Nowadays, the next step, and we don't have this available in my department here in Berlin because it's really expensive, is our intraoperative CT scans. But if you have this available together with your trauma or neurosurgeons, then it's in complex cases of the facial skeleton, it's really a dream to work with this. Secondary cases are especially a challenge in the craniomaxillofacial field. As you can see, he had a panfacial fracture and he was very upset about the post-operative asymmetry that that was the result of the initial treatment. And to correct this, it's not easy. So here we planned on the computer before going back for surgery, the re-osteotomy of the zygoma, correction in the LIFO-1 level in terms of an orthognathic procedure. And to get this transferred to the surgical field, we used individual guides and plates. And you can nicely design these individual plates to take care of dental roots. You can look where is still bone available, especially in secondary cases. And here are the guides for the pre-drilling of all the holes. And then you go classically for surgery. You open the old scars of the initial fracture treatment. You put in the guides. You make the LIFO-1 osteotomy in a classical way. You use the pre-fabricated individual plates to give the mandible, the maxilla and the zygoma the exactly predefined three-dimensional position. Here for the occlusion, we know where to put the mandible. So here we go with the classical BSSO, and right you see the postoperative imaging. And this is something that we are using more and more in our classical orthognathic cases. So we are really switched from the classic model surgery and the dental lab work to the computer to make everything virtually, coming from these very complex secondary cases. As you can see here, if you have the data of your patient available, you can really simulate the movement. You see the soft tissue changes. You see the changes of all your marked points in terms of the orthognathic analysis. And you can show even the patient an idea how he will look after the surgical procedure. Even on the computer, you can adjust the occlusal plane after the orthognathic procedure. So in general, if you make any kind of virtual planning, what is the principle behind? We have a preoperative situation. Let's talk about a trauma case or for secondary correction, or use an orthognathic case. So we have the preoperative situation and we need 3D imaging. We need 3D imaging of the bones. We need 3D imaging of the occlusal planes. You can digitalize your model impression, for example, or your casts. And we need some clinical pictures of the patient. And then we simulate our procedure. So we have a new position of segmented bones. And for this, we design the final plates for the new position of the segments. And then we can design the plate, and this will be produced. It's from titanium 3D printed individual titanium implants. Then we are going back to the original position of the bones, but keeping the holes of the final implant. Then we design the guides around these holes, and even for the cuts, we get an orientation where to cut the bones. And then we get the guides for pre-drilling and the cutting. You can use it for the maxilla, and this is where I like it very much, or even zygoma. For the chin and the mandible, I don't like it, but it's available and you could use it. But there's no need, in my opinion. So from the litho 1, you see the guide, even for a segmentation in the midline for the maxilla, and on the right side, you have the implant. In reality, just a case, litho 1 osteotomy before the separation. And here we did the down fracture and it's cut in the midline. And then you just see how this plate gives us the three-dimensional position, new position of the maxilla. And this is really, really very, very helpful. And with this, you can even go for surgery first. So you start with the skeletal surgical work before the orthodontic is coming with his part. And it's not working in all cases, but in most of the cases. Here, just an example, classical skeletal class 3, and we did a Bimax procedure with segmentation of the maxilla. Here, the guide for this patient pre and post-op, and so we did surgery on the day after he received his braces. Here you can see the occlusion pre-operatively and the final occlusion at the end of treatment. Pre-operative imaging, post-operative imaging, individual plates for the maxilla, hand-banded plates for the mandible. And you can use this kind of principle even in cases of sleep apnea when you want to make a bimaxillary rotational advancement. Here the detailed analysis, you know exactly where the nerve is running, patient pre and post-op, sleep apnea cured. Very elegant, and you can clearly discuss this workflow with the patient. And you can even make it more complex. You can even extend it to osteotomies of the zygoma in cases where you have this hypoplasia of the midface. And of course, your implant gets a little bit bigger and it's not so easy to get it in, but the effect in terms of the cosmetic result is excellent for the patient. Here you see this implant, here you see the surgical site, how to get it in, and you see laterally these additional osteotomy lines for the zygoma. Another case that came to us in Berlin from, I think he was coming from Libya after a war injury. He lost his right globe, very complex lateral midfacial fracture, loss of the right maxilla, big fistula, loss of the nasal framework, scarring of the right nasal airways. And I'm sure, especially in Saudi Arabia, you see some of these kind of patients after their road traffic accidents or even after some injuries by shootings. This was the preoperative imaging for us, the intraoral situation. So what to do with a patient like this? As you heard before, we would go for preoperative virtual planning. And by this, we want to reconstruct the missing bone by a fibula free flap, combination with the reosteotomy of the zygoma to put it more laterally in the correct position. We would remove the dislocated lacrimal bone, and this was our plan. And then we transferred this plan to guides and individual implants. At the end, it's like a big puzzle where you put everything together, but no hand bending of plates on the surgical field. Here you see the coronal approach. You see this prefabricated plate giving us the correct position of zygomatic arch and zygomatic bone, allowing us to restore the original width of the face and the anterior projection. In parallel, the second team is harvesting the free flap of the fibula and also already inserting the plate to the fibular bone. Then this was transferred for the maxilla for intraoral reconstruction, and this skin island was used for the paranasal soft tissue deficiency. Here you see that we used a little bit of additional bone from the fibula to reconstruct the nasal framework. Patient immediately after surgery, of course you have a huge swelling, intraorally the muscle cuff of the fibula for secondary healing. And here's the results 6 months post-operatively. Of course, not normal, but better than before. And now we can think about dental implants. We can think about an artificial eye. And for very, very challenging defects, we have now one more option available. This was developed by the colleagues in Hanover. They call it IPS Implants Preprosthetic. And the principle is a little bit like a subperiosteal implant from the earlier days, that you put a patient-specific plate on the bone. And these plates have already the dental abutments included. So you have a transition to the oral cavity by these big implants. I'm a little bit skeptic and a little bit nervous to use these kinds, but the colleagues from Hanover are really enthusiastic about it. So we tested in one case. Here you see patient was rehabilitated by alloplastology, and it was a very nice result. But however, the retention elements after 16 years get lost. So we were forced to do another procedure, but the patient doesn't want to have a free flap or a big procedure. So this was the situation. So we analyzed the bony situation. This was the intraoral situation. We were doing a virtual backward planning coming from the dental situation, put it all together where we want to end up. And then we designed together with the company these individual implants, even with extraoral retention elements. You can see, and then this is how they look like. So it's not a big procedure because we do not do any kind of tissue transfer, but we have to open, we put it on the bony surface, we fix it. And here you see, you can see these kind of abutment elements for the later prosthetics. And here you can see in more detail on both sides. This is the patient post-operatively, and now we are working with our dental lab to get the defect closed by prosthetics and anaplastology. So with this was really a quick overview of this current, how we deal with facial trauma and facial defects at the moment in my department in Berlin, and you're very welcome to visit. However, we do the same kind of procedures together when I visit the Saudi German hospital group. So most of the techniques you have seen in this presentation can be done on site in your country. So it's always my pleasure to come and to work with the colleagues on site. With this, thank you very much for your attention.
Very appreciated, Professor Max, and very nice presentations. And I do think that we have a lot of input from our participants and our colleague here in the. Can we start with our colleague who are with us? Professor Hashish, you are with us?
Okay.
Can you hear us?
Yes, please.
Yes. Thank you very much, Professor Max. It's really very nice and interesting lecture.
Can you raise your voice, Doctor?
It's really very interesting, and we'll cover the lecture, especially that you introduced to us now the intraoperative 3D CT imaging, how it could help for good performance, and particularly you stress on the prefabricated plate. How can it play a good role in the secondary correction. So I hope that we will catch this technology, especially the virtual planning and the prefabricated, the different shapes of plates for different cases. Now the for artificial eye, we believe that the early we reconstruct the orbital walls, so it will help, it might help the early movement for the temporary artificial eye. This is will be the first question. Could you please explain how far this remodeling and reconstruction of the orbital walls, saving the uh, orbital muscles, will help and give this kind of movement to the artificial eye, whatever it is, temporary or permanent? The second question, the role of mid-bore reconstruction, the sheet particularly, because the pre-shaped blocks of mid-bore, it's not that easy to fit with every case. But
Mhm.
the sheet, with sheet, we can reshape it according to the case to avoid the blood collection between the surface of bone and the sheet, so it will give more success. Thank you.
Thank you, Prof. Hashish, for your nice questions. The first questions in the initial trauma management, it is two things are important. First, to restore the orbital volume as it was before the trauma. And depending on the loss of the orbital walls or the destruction of the orbital walls, it can be helpful to use Titaniummeshes, pre-bended, bended on the table, or even patient-specific meshes, depending really of the extent of destruction. Then you ensure that all the orbital tissue is on more or less on the original position. When the globe is gone and is destroyed by the trauma or has to be removed, then of course to preserve all the muscles in the correct position makes everything easier with the artificial eye post-operatively on the later rehabilitation of the patient. So immediate goal is to restore the volume, that all the tissues that can be preserved are in the original position. Regarding the medpore is, I think you're thinking about secondary corrections if you have some soft tissue asymmetries after a complex procedure. And with this, you can, with medpore, you can use it like shaping on the table, or you can use it even as an individual implant nowadays. You can use the same workflow as I've shown you, that you send the data, you make a virtual planning, even with medpore. So you get a really patient-specific medpore implant. So you have with medpore two options. You can use it from the block and you shape it on the table, or you can get an individual implant. However, even the individual implant can be modified on the surgical side because it's the same material, but sometimes it makes your life easier. However, medpore for secondary correction of asymmetries, if you don't want to go for osteotomies or even bone transplants, it's a very nice tool to improve the cosmetics in your patients. I totally agree with you.
Can I just ask on one in between, Professor Max?
Yes.
What happened sometimes intraoperative, when you do the virtual planning, intraoperative, you see or you face the problem that your implants are not really, particularly maxillofacial. I know you must be 100% exactly, otherwise you have problems. But sometimes you have these problems of soft tissue coverage and implants fitting.
Yeah.
What actions you do if you face this problem?
Dr. Batagi, you're totally right. First of all, even if you use prefabricated implants, you have to know all the old techniques, how to solve it without the computer. So if you're lost with your patient-specific implant, you have two options. First, you can try to modify your implant, to shorten it, to bend it a little bit, to adapt it to the intraoperative situation. or let's say you throw it in the trash and say it's not working. We have to go back to the traditional way how we solve the situation. So nothing in medicine is 100%. Even in maxillofacial, nothing is 100%. So you always have to be able to switch back to the original established techniques.
Nice. Thank you.
Okay,
Can we go to the next panel?
Yes, yes, Mohsen, I will ask just one question, please, Dr. Khalid. Professor Max, thank you for this valuable presentation regarding the malunion panfacial fracture. As you know, there is different schools regarding you should start from up to down or from mandible to midface, like the old theories. Here, this case, what is the reason and how to avoid this malunion, especially in panfacial fracture?
Yes. In panfacial fractures, what I would like to do first is the mandible, especially if the joints or the condylar area is affected, because this is like a different approach, and it should be because of the joint. It should be really under sterile conditions. So I usually like to restore my mandible first. And then I come from up to down. If I have the mandible intact, then I come from, let's say, with a bicoronal incision to restore my width of the zygomatic arches to get the frame. So then I have the lateral part and the caudal part restored. And lastly, I do the midfacial complex, and the occlusion is crucial. Sometimes I have some bone gaps between the lateral zygomas and my midfacial part, but the occlusion has to be perfect. So I accept distances in the LFO1 level, let's say so, but the occlusion has to be correct one.
Thank you.
Any more questions from Dr. Kamal?
Yes. Thank you so much, Dr. Max, for your great experience and sharing your experience with us. My question is about the titanium implants, titanium mini plates,
Yeah.
and how important they are to be removed after fulfillment of their objectives in the maxillofacial surgeries, and what are the complications that can we face if any, if we leave them after fulfillment of their objectives?
Yes, usually we are advising our patient it is not necessary to remove the titanium mini plates because they are really, let's say, biocompatible and are working nicely. Sometimes we get problems and we get exposure of screws or plates, then we have to remove them. If we have some plates from the, let's say, in the intra-orbital area, sometimes especially the ladies are a little bit worried because they might feel the plate, then we have to go back again and take them out. The only area or the only two indications where I would really say take them out are children because of growing skeleton, sure. And the second is if it's really in the joint, in the condylar head area, because if we get their bony resorption, then we might affect our joint by the metal that is exposed. Otherwise, as you know, these implants are very nice, very nicely working, whatever company you use, and most of them, you can just leave them in place and the patient will come back if he has some complaints. So I think
if you have to remove them, when you remove them?
Not earlier than 6 months. Usually I say 6 months in the trauma. Sometimes you can go a little bit earlier, but it's different from trauma and orthopedic work because we have no really load on the plate. So we have not negative effects on the bone when we leave them in.
And about children?
Children, yeah, then we are about 3 to 4 months to remove them because if we wait too long, then the bone is growing over our implants and then it's really a nightmare to take them out. So in children, depending on the severity of the fracture, usually 3 to 4 months to take them out.
Regarding the children, we can use a resorbable plate, Prof. Yeah. Resorbable plate. It's nice for the children.
If you have them available, first point. Second point, depending on the complexity of the fracture. If it is too complex, because the implant regarding the stability are not the same as titanium. And regarding the area where you want to put it, you need enough bone, because the implant has a little bit more volume and is bigger in size. So if you can solve it with resorbables, very excellent. If not, take titanium, very small titanium implants, and do not remove them too late.
Yes, we have Dr. Ahmed Abdallah. Any questions from your side?
Hello, Doctor.
Aywa.
Hello, Doctor. Good evening, everybody, and thank you, Dr. Max, for great lecture. I want to ask you one question about complication, intraoperative or postoperative complication regarding drilling inside the inferior alveolar canal during plate insertion. For how long, if the inferior alveolar nerve was injured during the drilling or during the insertion?
Management.
How long it may recover, takes to recovery of inferior alveolar nerve?
If you
There's a lot of cases like this here.
If you see intraoperatively that the nerve is completely destroyed by something, by the trauma or even by drilling, usually you should address this immediately and try to suture the nerve.
Significance of
if
we face a lot of cases like this here.
If you just touch the nerve,
and if you get experience, you prefer to use endoscopic.
I hear another voice.
There is another voice. Can you mute yourself? Yes. Can you repeat, Professor Max, what you have said?
Yes. So if you really the nerve is destroyed by the trauma or even by surgery intraoperatively, and it's really disrupted, then you should try to suture it immediately on the table, because otherwise it is really it is not really to expect that it will recover by itself. If you just touch it, but the nerve is intact, I would continue the surgery, of course, not to insert a screw in this position, but just wait and see, because by months it can come back. Then you have time. If you see on your postoperative imaging that one screw is in the nerve and you didn't recognize this by surgery at the time of surgery, just take this screw out and leave everything as it is, but take the affecting screw out. So you really have to judge your postoperative imaging very carefully that the screw positions are correct, or even in orthognathic cases, the same.
Okay, I will come just to Dr. Mohammed Abu Saud. You have questions?
Yes, Dr. Ibrahim, yes. Dr. Max, I would like to ask you one question regarding the medial wall fracture. And from your great experience, do you prefer to use this endoscopic repair for this type of fracture using a polyethylene plate instead of external incision with a titanium plate? And what is the possible complication maybe happen with this type of fracture? Because we face a lot of cases here with this type of fracture. And the protocol in Germany in the medial wall fracture by endoscopic repairing.
You mean the medial orbital fracture?
Yes, medial orbital wall fracture, yes.
To clinically examine your patient, because on the x-rays, sometimes you see a huge involvement, but clinically the patient is fine, has no symptoms. So not all of the medial walls have to be addressed by treatment, although some of the imaging looks really impressive. So clearly judge clinically your patient. Even you can wait some days that if the patient has problems, then you should address. How to address this? Usually we address this from a transconjunctival approach, going through the caricula to go in the medial area, because by this you can really expose the medial wall, and then you can insert some of the resorbable implants or sometimes a mesh. In the very extended cases that you might think of, remembering the road traffic accidents from Riyadh, then if you're coming from a bicoronal approach, you can explore the medial from above, coming from above, and you go down coming from top down into the orbit, even to the medial wall. So, but remember, not all of these fractures has to be treated surgically. Just leave them if they have no problems.
Okay.
I have one question from participants. Professor Max, what is your protocol in the management of the condyle fracture in young and elderly patients, unilateral and bilateral?
Many aspects in the question. Let's say
yes.
so.
It's another lecture.
Yes, we go more and more to surgical treatment of condylar fractures in general. If we have a condylar base fracture that is non-displaced and the patient has no problems, no symptoms, we just don't do anything, even no IMF, because we just observe the patient for follow-up. If we have problems with the occlusion, we can re-evaluate and make another imaging, if it's a non-displaced condylar base fracture. If we have fractures going more in the neck area of the condylar process, it depends. In children, if we have a displacement and we can address this by surgery, we would replace it and fix it by resorbable or even by titanium. In adults, the same. If we're coming to the condylar head, it's really a very individual question. The first point, if we have children, we go more and more conservatively. However, there are some departments in Europe that even treat condylar head fractures in children surgically, but we would really be more conservative. In elderly patients, it depends on the level of destruction of the condylar head. If we have only, let's say, small pieces, there's no benefit from surgery because there's nothing to fix. If we have a huge, one or two huge fragments that are relevantly displaced, we would go for surgical treatment, especially when the vertical dimension of the ramus is affected and is shortened because of loss of the condylar head. And remember, the highest point of the condylar head is not lateral. It's a little bit on the top of the condyle. So this has to be taken into account when you judge the vertical dimension. So if the vertical dimension is reduced by the fracture and you have big pieces to fix, we would go in for surgery. How to do surgery? I like in these cases very much the set by Medartis because they have some microplates in it and longer screws. The final fixation of the condylar head is by screws, 2 or 3 screws has to be inserted. And the microplate is just for temporary fixation.
What is the difference now? You have said some European surgeons are preferring to do surgery in children,
yeah.
The others more conservative. Why you don't like to? We have the same debates about children in orthopedics.
Yeah,
but
I think so.
Maxillofacial, I don't know whether you follow the same rules or you have different rules.
It's really an individual decision, Dr. Khalid Bathagi, because there's no evidence in the literature in children what is better. There are some that saying, okay, we can do it and we do it in adults, we do the same in children, but is it really a benefit for them? No one knows. The condylar head in children has a high potential of let's say, regeneration and regrowing. So in the earlier days when there was no surgery in children, the results were not all bad. And so because the regeneration of the condylar head in younger patients can happen, there's really an indication not to do anything, because surgery in this field can be very difficult. We have the facial nerve, and the facial paralysis postoperatively in a child is really like a disaster. So it's really have to take into account.
Thank you very much. Thank you. I just want to go a quick round. If anybody from the panels have questions, because we are approaching the end of our webinar tonight.
Yes, Dr.
Professor Naim.
Yes, it's not a question, it is a comment. On behalf of all our colleagues in SGH group inside and outside Kingdom. We are really thankful to Professor Max Highland for this very fruitful and nice presentation. We are thankful, Professor Max. In the meantime, we are honored and thankful to Professor Khalid Batargi that he makes this event true. Thank you very much, Dr. Khalid Batargi. You are sharing
thank you.
us. Thank you very much.
Thank you. This is a closing remark. It's not a, that's a comment. Okay, if we have no questions, I really thank all of you. I like to thank Professor Max for his well-delivered lectures and informations. I like to have also the participants. We have today a huge number of participants. Almost over 1,000 participants were with us, and most of them, they did not leave the lectures. That means it was very interesting for them to participate. We have received also a lot of questions, and I think we have gained more information, particularly me, because I'm more on orthopedic, but sometimes I just have some fun doing some maxillofacials. Thank you, all of us, all of you, and have a nice time. Thank you
Hope
very
to
much.
see you in person
Thank you.
soon again. Thank you.
Thank
very
you.
much.
Thank you so much. Thank you.
Thank you. Thank you very much.
Thank you very much.
Thank you very
Thank
much.
you very much.
Thank you. Bye-bye.
Thank you. Bye.
Bye-bye,
Thank you,
Prof.
Professor Omar.
Thank you, Prof.
See you soon in Egypt.
Hope to see you soon. Yes.
See you after Corona.
Yes, after Corona. Yes, I hope so. Bye-bye. Bye-bye.
Okay, bye.
Okay, bye.
Bye.
Bye bye.
مع السلامة يا محسن.
السلام يا السلام.
نشوفك بخير يا حبيبي.
إن شاء الله.
مع
السلام.
السلامة.
مع
مع
السلامة.
السلامة. مع السلامة.